It's on the trail.
Normal chest rest.
We don't know. It's likely the guy was stabbed, otherwise he wouldn't get the x-ray, right? But there's nothing stopping this patient from having a knife just laying on their belly on the top, and the x-ray makes it look like they're being stabbed, right? This is the importance of having dos views, right? 2 views is what tells you what's actually going on with this patient. So that's why I put this up there, like you don't know without 2 views. Now, obviously, if you saw the patient, you should be looking into the colors and making sure they're not just hiding a knife laying on their belly. But anyways. All right, so we're going to go over heart and great vessels today and the airway a little bit. Really, we're going to start looking at disease processes, focusing on both of these areas. We get into congestive heart failure today. Now, what I will tell you with congestive heart failure, the way that I do this is I start off with congestive heart failure, CHF, because it has a lot of the abnormalities that we can find on a chest x-ray. We're going to go over each of those things and kind of what it shows and what it looks like. After we get done with CHF and we start going to these other cardiac and pulmonary disorders, understand that the majority of them can all lead to congestive heart failure. Congestive heart failure is an end-state disease, right? It's something for somebody who's been sick for a long period of time with a particular condition, uncontrolled hypertension, maybe COPD, maybe pulmonary arterial hypertension, all things we're going to cover, but it wasn't treated, it wasn't taken care of, so over time it has led to congestive heart failure. If you don't contract it, you don't get it from anybody, right? You don't just magically get diagnosed with it without some other diagnosis that has either been missed or that the patient has been living with for a long period of time, and now we've reached that congestive heart failure. Does that make sense, right? So a lot of these diseases you get, we got to treat. This is something that you get from long-term lack of treatment or lack of diagnosis with certain conditions. So before we get into that, we're going to talk about cardiomegaly. We're going to look at maybe some neuropericardium today, and then we're going to get into some of the aortic stuff as well. So what is cardiomegaly? Cardiomegaly definition is the heart more than 50% the size of the width of the entire thorax, right? You're going to ballpark that with your eyes. I don't need you on a test. I'm not going to make you measure it and be like, well, the thorax is 75 centimeters and the heart 75 divided by 2, 37. Oh, the heart's 37.3 instead of 37.5, so no, it's not cardiomegaly, right? Not going to do that. It's going to be an eyeball kind of thing. So if I give you a cardiomegaly on the exam, it'll be clearly more than 50% of the width, so you don't have to actually measure it. But the actual definition of that is the width of the heart, or the cardiac shadow, more than 50% of the thoracic width on the PA. On the lateral, does the heart overlap the spine? So yesterday we looked at those lateral chest x-rays. We saw that retrocardiac space to where there was the heart, there was the spine, and kind of in between there was that darker, more radiolucent area. We call that retrocardiac space, right? If that's missing and you see the heart starting to go over the spine, that's another way you can say, hey, this is cardiomegaly. Okay, so those are the two definitions of that. The catch with cardiomegaly is it the heart? Is it not the heart? We don't know. Cardiomegaly is more of an observation, but something caused that to happen. So what does cardiomegaly mean when you see an x-ray? It means you have to do more digging. You have to find out, why do I have cardiomegaly? Could it just be an enlarged heart? Number 3, true cardiomegaly, like from left ventricular hypertrophy, which we'll talk about from like long-standing hypertension. Yes, it can be. But because fluid and soft tissue look the same on x-ray, we don't actually know just from the x-ray if that's the problem or not, right? It could be a pericardial effusion. I could just have fluid in my pericardial sac and it's still going to look like cardiomegaly. It's not true cardiomegaly, but it's fluid related. But I don't know that on just the x-ray, right? And then there's some other extra cardiac factors that we'll talk about that can make it look enlarged. So that's why I say the definition of cardiomegaly is like, yeah, technically it means enlarged heart, but understand when doing it based off of films, it's more of an enlarged cardiac silhouette. And you then have to do the investigation of why is that heart enlarged. You'll learn more about that in cardiology, but I just don't want you to marry up, I see it's large, so it must be the heart that's big. It could be other things as well. How would you further evaluate some of those things, right? So a pericardial effusion. If you suspect a pericardial effusion, you can either you really won't do the ultrasound because the ultrasound's going to be in trauma, right? That fast exam, you can technically see it on that fast exam. But if they're trauma, you're already doing the trauma workup. This is just a standard patient coming in with chest pain, no trauma. You do a chest x-ray, you see what looks like cardiomegaly, and you're like, I think this might be a pericardial effusion based off of the fact that when we learn about hypertension, like they're not hypertensive, they're not on meds, they haven't had a history of hypertension, so I don't think it's the heart. I think it might be something else. A CT will show you the fluid within that pericardial sac. Okay? Because of the detail of the CT, even though it's still kind of x-ray related, you'll be able to see the difference between the heart muscle and the pericardium on a CT. It always fills from the left side first to the right side, right? Because of the way the heart sits. Remember the way the heart sits. When they're lying down, flat, and they're getting a CT, the left side of the heart is what's more kind of posterior with the way it's rotated and sits, which is why it fills from the left around to the right in that pericardial sac. All these other causes, right? Again, pericardial effusion is being caused by something. What? Congestive heart failure, infection, cancer, uremic pericarditis, lupus, trauma, post-pericarditis syndrome, so many things. Don't worry about that right now. It's just going to show you again, this is another symptom of something to tell you that something else is causing it. So again, we're using these things in adjunct with the patient. You will get it more in cardiology. Ultrasound can be used to identify pericardial effusion. We talked about that. You'll see that again in the trauma EFAS stuff. CTs can show the small ones. And we already talked about why plain films are poor at defining those. So again, just showing you that the X-ray gives you some information, but it's not always 100% diagnostic. You need to do more work done. What are some extracardiac, what are some extracardiac factors that is not the heart being enlarged and make it look enlarged? Well, first thing, magnification. All right, they did an AP chest X-ray. You didn't realize it was AP chest X-ray. The heart's going to be enlarged. It's not really. It just looks like it, right? The other thing we talked about yesterday, that suboptimal inspiration, that crowding, makes the heart kind of smush and kind of make it wider. So which is why when you see cardiomegaly, your next step before you call it that, count those ribs. Make sure you got those 8 full posterior ribs. Be like, we have enough inspiration. It's not the diaphragm, bless you, that's causing the heart to get crowded, right? Obesity, pregnancy, ascites. I have it in there. I used to just ask why, but I just put it in there, right? Inadequate inspiration. Why? Right. I have more pressure on the diaphragm. Even when I try to take a breath in, obesity, I got that visceral fat, right? Pregnancy, I have a giant parasite, right? That's what they are. Hey, listen, I got 3 kids, my wife says it, they are parasites. They take all of the energy and nutrients from mom. That's the definition. Really, they're cute when they come out, right? And then we love them and we raise them. And then parasites on the wallet as opposed to the body after that. But 3 kids are actually pretty good. But anyways, they're pushing up on the diaphragm, so it makes it hard for mom to take a breath in and to get enough of that inspiration because they have the uterus and baby which is pushing up. Ascites is more of a pain thing. When they have the ascites, trying to take a breath in can be difficult, and it's got the fluid and the pain causing that pressure. So that's what causes inadequate inspiration. The patient just can't do it that well. But it doesn't mean they have cardiomegaly, right? But it's going to look that way on the X-ray. Chest wall abnormalities, pectus excavatum. You guys heard that yet before, right? Where the rib cage is kind of pushing in, so it kind of rotates in. My son has this a little bit. To where the ribs come around and the sternum is kind of more internal. And so depending how bad that is, that can actually push on the heart, causing it again to kind of get smushed a little bit and widen out, causing what looks like cardiomegaly. So that's something to be consider. Rotation, either way, usually more to the left, so looking for the ribs, but then also looking at the sternoclavicular joints, because if they are more rotated to the left, that left ventricle on that side of the heart is going to come more to the side of the thorax and look kind of big. Now theoretically, that also means the right atrium would kind of be almost non-existent because that would rotate to and sit behind the spine. So when you draw out your heart, it might not quite be that 50%, but depending on the patient, that rotation can play a role. And then finally, pericardial effusion, which we just talked about. Okay, so here is a generalized picture of that 50% of the thorax, right? It's a gross estimate. Gross estimate. So don't get hung up on trying to figure that out if the question, if none of the answers are cardiomegaly. Right? Don't get, I don't know. If I'm not asking to pull out cardiomegaly, then don't waste your time on the test trying to analyze that portion of it. But just understand, on your tools when you're in clinic, you will have a measuring capability. So like if you're borderline when you're in the ER, you're getting a chest x-ray, you're doing your rotations, you'll have calipers on there that you can just pull up and go click, click, all right, click, click, yep, we're good, we're not cardiomegaly. So you'll be able to do that in clinic, which is here, I'm just gonna give you a ballpark on it. Here's a normal and an abnormal. Okay, so thorax, heart. Thorax, heart, right? These are the kinds of abnormals that I will give you if I want you to know that the patient has cardiomegaly. To be honest with you, a lot of times the cardiomegaly is going to be on the chest x-ray, but we'll be asking you for different conditions or different things. But lateral, see how I got my retrocardiac space primarily here and here, okay? I still have a little bit of it here, but I don't have any of it here. I don't have that darkened area. I'm going to erase again. So again, I got this darkened area right behind the heart, between the heart and the front part of the vertebral bodies. I should have that. That's a retrocardiac space. I should have it here, and I should have it here. When I go to my abnormal, I would argue, yeah, sure, I got some right there, but I don't have any radiolucent retrocardiac space there. And sometimes it's bad enough to where instead of the border of the heart being here, it'll infringe into the border of the spine. Again, it's not touching on the spine, it's not pushing on the spine, right? It's just sitting in an area either in front of or behind, causing the shadow to go into that anterior vertebral body. Most of the time, you're going to diagnose this based off of the PA, right? Most of the time, this is where it's going to stand out. But the lateral can be used if you're borderline kind of concerned. Like, I think it is it not? Go and see if there's any retrocardiac space or in both those areas. If there is, then you're good. If there's not, then it's likely going to be a cardiomegaly. That's the definition and the basics of cardiomegaly. Do we have any questions on that? Yes, sir.
Back to the slides. The outer margins of that, are a little bit more radiolucent. Is that infusion or?
Yeah, that's right. And that's what, so this particular patient, I think, and I tried to look it up before, I don't have the actual like report on the patient, but what I think this one might be is a pericardial effusion, because what I see here is I have like my main heart wall there, but then it is a little bit more radiolucent in this area, but we include the whole cardiac seal when we do the measurements. Yeah. Other questions on cardiomegaly, definition of it, how to find it on a PA or a lateral chest x-ray. Okay, understand, it's not a final diagnosis, it means something's going on, and then you as clinicians will have to do the legwork to figure out why, what's causing it. Okay?
Sir,
Yes?
on that lateral
Yes.
picture, what are you pointing by those white and red arrows?
So what did I point there? Oh, the arrows are just showing you the difference in the, remember we talked about that spine sign, right? How it's lighter here and then it gets darker down here. That's normal, that's meant to show you that. And then so like over here, I don't have spine sign, it's all the same. So like I'm not necessarily getting darker going down, whereas on my normal, I am getting darker going down here.
Thank you.
Thank you for pointing that out. All right. Other cardiomegaly questions? Okay. Our first abnormal condition. this is what, similar to block 1, a lot of the abnormal diagnoses slides are going to look like. More so than block 1. Focus a lot on symptoms and then radiological findings. Because a lot of these chest x-rays are going to look very similar. Now, we don't have anything to go off of yet, but you'll see as we go through these things. I will also try during lecture to, when I hit certain things, I'm like, hey, this is different than this because of this piece. For example, this one has fevers, the other one doesn't. Things along those lines to try to help you kind of differentiate for you as we're going through it so you can make notes as opposed to trying to pull it out of the slides sometimes, okay? So, congestive heart failure, right? Final common pathway, kind of what I said at the beginning. Final common pathway. I don't care what your disease is, your cardiology diseases, or some of your pulmonary diseases, it can lead to congestive heart failure in some way, shape, or form, right? So what do we usually see? Well, you're gonna see a lot of these symptoms are gonna be the same in a lot of this chest stuff. Decreased exercise tolerance, dyspnea on exertion, weight gain, right? Probably pretty common because they're not doing the exercise and stuff like that anymore. They're fluid retaining. Fatigue. Some of the key things with congestive heart failure. Left-sided orthopnea, but really that paroxysmal nocturnal dyspnea. Big fancy words, right? What does that mean? Hey, the patient's not gonna be like, hey, I'm having paroxysmal nocturnal dyspnea, doc.
Why?
Right? Maybe if one of you goes to see it when you're open, you go, talk about great, right? No. What's the kind of things they're gonna say that's gonna key you into that? That's gonna be the, hey, I've noticed over the past few months or whatever, when I go to sleep at night, I have to put some extra pillows. Or I gotta sleep in a recliner, right? That paroxysmal nocturnal dyspnea is when I lay flat and try to sleep, I have a hard time breathing. But if I prop myself up in a recliner or have to add a couple of extra pillows behind my head or my shoulders, I can usually sleep okay, right? That's the paroxysmal nocturnal dyspnea. The left-sided orthopnea is the same concept, but it's when they lay on their left side, they're having issues, okay? But it's that right there, you start thinking congestive heart failure, all right? And we'll see why when we look at the x-rays. Yes, sir?
Is it only on that side? For the
So the paroxysmal nocturnal dyspnea, no, it can be when they're laying flat as well. It depends how severe it is. It can be really kind of anywhere. It's just more commonly left-sided issues.
Wait, someone has that issue is definitively
No, if someone has that issue, you need to have it on your differential and be concerned about it, right? Not definitively always congestive heart failure. Nothing we talk about is gonna be absolutely definitive. There are other conditions in medicine that cause paroxysmal nocturnal dyspnea, right? For this course and the conditions we're gonna be talking about, that's gonna lead you towards congestive heart failure, and I want you to confirm that via x-ray or whatever the case may be. But you are gonna learn about other conditions. What this is basically saying is if you have this better be on your differential, and you better reevaluate for it to see if they have CHF, okay? Because there are definitely other conditions that have the paroxysmal nocturnal dyspnea. It could be a cancer, it could be other kinds of things causing that issue. But we're gonna talk about a lot of fluid things in the chest and the lungs. And the only one we're gonna talk about in this course that has the paroxysmal nocturnal dyspnea is gonna be CHF. Okay? But remember, CHF is a final common pathway. So can you have somebody who has one of these other disorders we're gonna talk about, like pulmonary arterial hypertension or regular hypertensive cardiovascular disorder, and that's what they have, and they come in reporting this symptom? Yeah, because they started with something else and then it leads to this. Okay? Alright, lower extremity edema, right? That's a big one. Why? There's a fluid overload. Congestive heart failure is a fluid overload. So that fluid is going to go other places as well too. And that's where you get like that penny edema in your lower extremities, right? Because we're having too much fluid, the body's not clearing it, it's filling up in the lungs, coming out of the vasculature, it goes down to why lower extremities? Gravity, right? Gravity is going to pull that down to the lower extremities. So what do we do for it? Well, first, initial study, shocker, chest x-ray, right? That's my initial study. There really is no study of choice on this because the chest x-ray is what we're going to use. A CT is not really gonna help you very much. I mean, it might show it as well, and maybe show some of the extent of it, but you don't need it, okay? All these things on the left side, we're gonna look at pictures of a lot of this stuff. All these things are different types of appearances of congestive heart failure, okay? So you can have pulmonary venous hypertension, that's gonna cause the sepalization and the enlargement of the central vessels. We're gonna look at that on x-ray. What does sepalization look like? We briefly talked about it yesterday in prep for what it looks like here today, all right? You can have pulmonary interstitial edema. That is just fluid in the interstitial of the lungs, right? So you're gonna get these curly bean lines, which we'll kind of look at. They're hard to see, but we're gonna show it to you. Parabronchial cuffing, fluid in the fissures, pleural effusions. We're gonna look at all of those abnormalities, and we're gonna pull those out and see what those things are. It can be worse. It can go into another stage and go into your pulmonary alveolar edema. That's gonna be fluid in your alveoli, right? So now that's gonna be more fluffy, patchy, bat wing or butterfly appearance. And because of the way the alveoli look, we're gonna look at pictures of that too. We're gonna use your imagination on that when we kind of draw out the butterfly and the bat wings. But that's the next stage of that. And also pleural effusions. Technically, you can do an echo, right? You can do an echo, which is a dedicated ultrasound of the heart. But really what that's gonna do is that's just gonna try to figure out, is there anything structurally wrong with the heart? And sometimes it is, sometimes it's not. You don't need it to diagnose this condition. And we're not really gonna cover that very much in this course because you'll cover it a little bit more in cardiology, and you guys aren't gonna be reading these, right? If you order an echocardiogram, you're gonna send them to the ultrasound, they're gonna get the echo, and you're just gonna get the report. You're not responsible for interpreting, dictating echoes or anything like that, so we're not even really gonna touch it, because there's no value added for a radiology course to look at that. Two most common causes in the US of congestive heart failure: coronary artery disease and hypertension. That's a lot of Americans, right? I mean, it's a lot of Americans. There are other causes there. Look at all the other causes: cardiomyopathies, valvular lesions, arrhythmias, hyperthyroidism, anemia, shunts, right? Pulmonary interstitial edema, pulmonary alveolar edema are going to be signs of it. There's a lot of things that cause CHF. It is a final common pathway. Okay, so a lot of people ask me like, okay, so we diagnosed this. If we can't fix it per se, what are we doing, right? Because we got to fix the problem, not the CHF. The idea is finding this, that way you can treat the patient appropriately. Have you guys done diuretics in pharm yet? Okay, so you'll learn that more in a little bit in pharm, and then in pulmonology and in cardiology is really the answer is get them on diuretics and try to get this fluid out of their lungs and help their body unload some of it, just to make them more comfortable while we try to treat whatever the condition is that's causing the CHF. So, all right. So here's the progression of congestive heart failure. So what happens is we end up with pulmonary venous and even some pulmonary arterial hypertension, right? Here's the pulmonary vein. We end up with that hypertension in both of these vessels because of the fluid overload, right? It's not a vessel problem. We got fluids backing up. Things aren't working that well. So what happens, right? By standard kind of osmosis and pressure, fluid starts to leak out of our vessels, and it first starts to encircle our parabronchials. Remember how we talked about we can't see the parabronchials on X-ray, right? We see the vasculature. Well, when fluid starts to leak out into the interstitium, it sits around those bronchioles, and now we'll be able to start to see those bronchioles on the chest X-ray. We'll take a look at that. But it starts off with just in this area with some fluid around the bronchioles, giving what we call parabronchial cuffing, which we'll look at. Then as it gets worse, the fluid starts filling up the entire septa. It starts going in to the alveoli, it starts filling up this entire area, and that's where we get our pulmonary alveolar edema, filling up the entire lobules, and we get that patchy, kind of fluffy type appearance. We'll take a look at what that is too, okay? Can lead to increased heart size. This is all the fluid kind of getting worse and going throughout the lungs, but just kind of giving you the progression as we get into the chest x-rays, all right? I am not going to test you on severity level. I just want to show you the difference as these things get worse, all right? Don't worry about it if you're like, hey, what's the difference between these two right now and these two right now? Not hung up on that. just showing that there are multiple severity levels. As the same patient, we can progress from 0 to 1 to 2 to 3 and kind of see how things are going. We're gonna break this down on different x-rays, okay? So what we got here, I'll focus mostly on 2 and 3, and these are small, we'll look at bigger ones, okay? First thing I'm seeing here is, and it's small, remember we talked about the cephalization. Look at the density difference, radiopaque versus radiolucent difference in the lower third compared to the upper third of that severity level 2. It's not that much darker up top than it is on the bottom like we would expect to see, okay? We'll have bigger pictures. But that's one of those steps in that aspect. And you can't quite see it here, but it's really small. So we got, oh, I'm touching the screen too. There, some parabronchial cuffing there. And then later on, look at the difference really between the interstitial edema and the alveolar edema. Look at the patchiness of the alveolar edema. Look at how it's throughout all of those kind of lobes, and look at the different lung areas, and kind of just stands out, right? All of this here, it's very patchy, kind of fluffy white. That's the difference between the interstitial and the alveolar edema as it gets worse. Okay. Some more definitions on this, and now we're going to start looking at them by x-ray on the next slide, all right? Like actually big x-rays. So all of these abnormalities are things that we're watching out for. Thickening of the interlobular septa, parabronchial cuffing, fluid in the fissures. We'll deal with pleural effusions later and separately, and then the bat wing and butterfly stuff on both of these guys. Both of these are CHF. It's not like you have to get to the end thing to be like, this is congestive heart failure, okay? This is all part of congestive heart failure. It's like a stepwise process. So, the first thing we have is the thickening of the interlobular septa, or the curly B lines. These are specific horizontal lines. I'm going to draw them and then erase them. Horizontal lines in the distal 1/3 of the lung. They are straight horizontal. When I go my normal, I can see my vasculature, but I don't have any horizontal lines sitting here, right? This down here is a nice, clear, radiolucent area. Don't really have a whole lot of lung markings. I don't have anything that stands out there because everything is so fine at the bottom. When it's normal, I shouldn't see anything. But here on my abnormal, I have these radiopaque horizontal lines, okay? Here's the deal. I've never seen a curly B line on an x-ray, but it's in the book. It's a part of congestive heart failure, so I gotta teach it to you, right? Because it is an abnormality, and if the PANCE gives you a question and tells you the patient has curly B lines on chest x-ray, you need to know what that means, because they'll do that kind of stuff to you, right? But on an x-ray, I'm not asking you guys to pick out curly B lines, right? Look at the magnification on this just to be able to see those. Now imagine if you got to magnify that on your early NBD screens on an exam with a pixelated image. It's not reasonable, okay? But your preceptors may ask you, and the PANCE may ask you about curly B lines, and you need to know congestive heart failure sign because of thickening of the interlobular septum, okay? So if I point to something on a test and say, what is this? And curly B line is a choice. I'm not making you pull out curly B lines on the exam, okay? Because they're too hard to see in real life. You have to find a very specific image, but you have to know it because you will see that word in other ways, all right? Try to answer the question of like, why do you teach us stuff that we're not going to find? Because you're going to see it in vignettes and you're going to get pinned on it in phase 2, right? So, but that's what that is. It's thickening of that interlobular septa. So this area right here shows up at those horizontal radiopaque lines only in that distal 1/3 of the lung, typically close to that claustrophrenic angle. That's where we're going to see those. Okay. Now let's go on for something we are going to see. Parabronchial cuffing. Okay. Here's my normal, where we see all the lung markings, the vasculature lines, right? We can't see the bronchioles. But then here, I can see my bronchial, okay? And so what that is that is the fluid in the interstitium that has been leaked out and is now sitting around that bronchiole, so now it stands out. And it's not because the bronchiole is standing out, like the bronchiole, there's nothing wrong with that right now. It's the fluid in the interstitium that surrounds the airway that now makes it more prominent. Parabronchial cuffing, cuffing around the bronchiole, right? And so what these other arrows are starting to try to show, oh jeez, another review. This is trying to show some more fluid kind of in the interstitium, in that area. That's hard to see. I want you to focus on this guy right here, okay? And then the way to kind of word it on there, that ring-like density donut appearance, it looks like the bronchiole's coming straight out at you because it's radial opaque. Don't get that confused with something like this on the normal. What's the difference between the two? They're both round. One's radial opaque, one's radial lucent. So what the one on the normal I circled is, it's just the positioning of a vessel with fluid or blood, basically blood, that just happens to be going in the direction coming straight out at you, which is why we can see that nice circular instead of like the tube kind of linear projection. It's a nice circular cross section, right? But it's radial opaque. It's gray. It's filled with fluid. Whereas the parabronchial cuffing is that radial lucent center with the fluid around it. So we got that. Okay. So when evaluating for potential congestive heart failure, parabronchial cuffing is one of the things that you're looking for to see if you see it on chest x-ray. Fluid in the fissure. Remember how I told you to know where the fissures are so you have an idea if there's an abnormality? That's where the fissure is, right? So what's happening here? So we have fluid that is coming out into the area and it's in between the lobes, so it's sitting in the fissure. That's what that is, right? So I have my upper lobe and then probably my middle lobe is right about here. And so that is fluid in the fissure. Fissures are not typically visible. So if on a PA chest x-ray you can see a fissure very clear, then that's usually an abnormality. And there's probably fluid in there. Okay? It's always going to be thicker than that super, super thin line we tried to see yesterday. Really hard to try to see, but that stands out in that area. So fluid in the fissure, again, another sign of congestive heart failure. And if I look further, hey look. Look at my parabronchial cuffing in the other lung. Right? So now I'm like, oh, I got fluid in the fissure. Oh, look, and I have parabronchial cuffing. So now I have more signs towards that congestive heart failure. Hard to see right now. You guys are going to get good at this. Right there and right there. I got that radiolucent circle with the fluid around it, that donut sign, because there's fluid around those bronchioles going along with the fluid in the fissure. All right, looking at the costophrenic angles. So this is where our pleural effusion comes in. So look at my normal, sharp points. Sharp points at the end of my costophrenic angles. Okay? Here, it comes down and it's not really a sharp point, right? It's kind of rounded off. I don't have that nice sharp, jagged edge. More when I trace out the lungs, it's more kind of rounded, okay? What that is that pleural effusion. So fluid in the pleura. Usually bilateral, okay? The key thing on this is how much fluid do I have in there? Well, if I have if I have what's called costophrenic angle, like blunting of the costophrenic angles, that's a term for that, it's blunted, it's not super sharp. If I have a pleural effusion there, and I can see it on my PA, I have a minimum of 300 milliliters of fluid. Minimum. But if I only see it on the lateral, but I don't see it on the PA, I have a minimum of 75 milliliters of fluid. Why do I need more fluid to see it on the PA than I do on the lateral? From yesterday? because they're the anterior costophrenic angles and they sit higher. Remember we looked at that, we do that lateral chest x-ray to see what can't be seen. You see the posterior angles on the lateral chest x-ray because we can't see them on the PA because I have all this abdominal tissue that sits there that takes up all that radiation, right? So the first place you're gonna see pleural effusion as it starts is gonna be on the lateral and the posterior angles because gravity pulls fluid down, and it only takes about 75 milliliters of fluid to see that blunting. So you gotta get both pictures, right? If you see it on the anterior, because that pleural effusion had to fill up to get to the point to where you can see it in these higher anterior costophrenic angles, that's a minimum of 300 milliliters of fluid in the pleural space. It's a good way to give a general measurement when you're looking at a pleural effusion, like how bad is this? How much fluid is sitting there right now? You're not gonna be able to measure it exactly, but based off of your x-rays, you can be like, oh, somewhere between 75 and 300, but less than 300, or 300 or more. Okay? Pulmonary alveolar edema. So all of these things that we talked about in the past few slides fall under the interstitial edema stuff, right? Fluid just in the interstitial, that parabronchial cuffing, that fluid in the fissure, that's that pulmonary interstitial edema. The next stage of this is it's gotten worse, there's more fluid, and now we're in the alveolar area. So we have that pulmonary alveolar edema. So you get these patchy aerospace densities. So again, I'm gonna take this one, take a look at this real quick. I'm gonna go back a couple of slides. And look at my difference here, right? Not really super patchy. I can still see my lung markings pretty well. I got the parabronchial cuffing, but then when I compare it to this one, there's my difference, right? And so use your imagination here. A lot of times you end up with this bat wing or butterfly appearance. So the body of the butterfly is the spine, and then you have right here. The patchiness is typically centralized, right, in that area. I didn't use your imagination, guys. I didn't make up the terms, I'm trying to help you see it, right? But the patchiness is usually kind of centralized in that area. It's fluffy, it's patchy, bless you, and it's coming out from the spine. And so that's your little butterfly appearance. Usually your pulmonary alveolar edema usually spares the upper lungs. Why again? Because gravity is still working against it, right? It would need to be an entire opacity for it to just be hanging out in the upper areas just waiting to do its thing, right? So most of the time it's in the central or lower areas, but it's that patchy type appearance. A lot of times you'll have fluid in the fissure along with this. Well, that makes sense because we talked about parabronchial cuffing and fluid in the fissure of that pulmonary interstitial edema. And then this pulmonary alveolar edema is the next step, right? So if I see fluid in the fissure with this, yeah, logically I can work through that because they probably had the fluid in the fissure early on, and then now it's gotten worse, and now I have the alveolar edema, right? You may not have fluid in the fissure, but it's not abnormal for you to see that. But that is that patchy appearance. Now, that looks a lot like, when we get there, pneumonia, right? Pneumonia is going to have a patchy appearance. We're going to see that. But when we get to pneumonia, we're going to talk about the differences of how you can tell the difference between a pneumonia potentially versus a pulmonary alveolar edema. And spoiler alert, it's based off of the patient's symptoms and history. All right? The X-ray will help you a little bit, but it's based off of the symptoms and the history. Most of the time, your pulmonary alveolar edema, most of the time, is bilateral. Okay? Can it be in one lung? It can, but usually it's bilateral. Now let's talk cephalization. Okay, so it's got to be on an upright film. That's step one, right? It's got to be on an upright film. You cannot diagnose cephalization if this is a supine AP chest X-ray because the patient is bedridden, right? Why? Because the whole point of that is the backup of the fluid into the upper part of their lungs where those vessels aren't normally prominent. So I need it to go, hey, gravity's supposed to be working, it's not working, it's building up, there's that fluid. If I'm lying flat, what happens to fluid? It just falls out, right? So it's going to look like potential cephalization if you're supine, even in patients who aren't having congestive heart failure and having cephalization. So if you're going to use this as a tool, it's got to be on an upright chest X-ray. Sitting, standing, don't care. I need the thorax upright. Okay? But what you're looking at is you're comparing, here's my normal, okay? Comparing the densities of the lower third to the upper third. These should be darker than the bottom portion, right? As we go up, it should be darker because we have less prominent vasculature and gravity works against us. If I go over here, they're very similar. How do you learn seeing this? Practice, right? Looking at your normals, understanding your normals, and then there's other clues on this chest x-ray that can lead you towards possible abnormalities. Okay? What are all of those? These guys right here. Anybody know? Those are sternotomy wires. So this patient has had a cardiac surgery. Okay? Looks like possible stents in there. If it was pacemaker leads, I would actually see like the pacemaker sitting in here, but it's not. So it looks like they had some type of cardiac surgery, right? I don't know what, but some type of cardiac surgery, and that's for your sternotomy wire. So now that's another hint that this patient has some kind of cardiac past medical history that it fits with having congestive heart failure, so I'm not surprised in seeing that cephalization, right? Would we call that cardiomegaly? I probably would. Ballpark, I probably would. Even if not from the 50%, like, look at how much right atrium I have here. That's a lot more than we've been seeing prior, right? And so I would probably call that a cardiomegaly, right? But the key thing with this slide is really just looking at that vasculature, looking at that cephalization, and kind of being able to see that my densities are very, very similar with one another, and that's what cephalization is. This is one of the harder things to kind of wrap your mind around and be able to see when you're looking at the images. Do I have any questions on the cephalization right now? Okay, we're going to have more pictures. We'll take a look at it and try to see if we can find it, okay? This is not for me. This is for you, but more for cardiology and pulmonology and stuff like that. Just helping you understand that we're talking about congestive heart failure in this course, about heart conditions that are going to eventually lead to this. There are non-cardiac issues that can lead to congestive heart failure too, or lead to these types of things on x-ray, like the parabronchial cuffing or the fluid overload or those kinds of things. For example, smoke inhalation, near drowning, some pretty straightforward ones that you're gonna see these abnormalities, but it's not congestive heart failure. But it looks like congestive heart failure because of the damage that was caused to the lungs from some of these other things. I'm not hitting those, but I say that so that way you're like, oh, I see parabronchial cuffing, I see cephalization, I see this, so it's got to be congestive heart failure. Well, in real medicine, not necessarily. You got to figure out why, right? And they might have something else going on that causes it to have those abnormalities, but the heart's actually okay. All right, but FYI slide, don't commit it yet. You're going to hear about it in the poem. Here's a chart for you, for your clinic, to help you out with that, right? If it's cardiogenic, there are two things in particular that are going to be very common. Your pleural effusions usually is a cardiogenic reason. It is usually not due to smoke inhalation or drowning, near drowning, or any of those other diseases or anything like that. So if you see pleural effusion with some of these CHF things, you'd be pretty confident that it's likely cardiogenic in nature. The curly knee lines technically, but look for them, I guess, if you want to. I won't make you look for them on the test. Heart size is usually enlarged in cardiogenic reasons. It may be normal and non-cardiogenic, right? And then you'll learn this in pulmonology. Pulmonary capillary wedge pressure is going to help you with that. If that's abnormal and elevated, it's cardiogenic. What are you shaking your head? Did you already learn this? Pass?
When's the last time you said they wrote a pulmonary capillary wedge pressure?
Me, I work in outpatient family practice, so not often.
Even in the
But in the specialty career field, in your really sick patients, they still do it. Yeah. It's in the book, and you gotta know it, man. We give you a reference, I gotta teach from the book on some of these things. The biggest thing is understanding that the cardiogenic causes are due to the higher pressure that's spilling into those spaces, right? The heart is causing the issue, which is why the pleural effusion, the curly V lines, because it's that interlobular septa, right, are typically present in the cardiogenic causes, whereas they may not be in the other ones. But that's more for your chart for clinic, because that's FYI, which makes that FYI, okay? Because I don't think I put it on there, it's not on there. There you go, all right. So, let's practice. Yeah, CHF, it's not that easy. What abnormality would you, and I recognize, right? So for those of you that are like, that's a trash x-ray because I can't see the spine, right? Good job, it's underexposed. But in this case, it was one that I was able to find all the abnormalities to be able to show you where things are at. So, what abnormality we talked about would be, start down there, would be echo. Once you have the contraphrenic angles, which means it's what? What's it actually called? Pleural effusion. But yes, also because I can see it here, minimum 300 milliliters of fluid, pleural effusion, because the abnormality on the x-ray is blunting of the contraphrenic angles, so that would be what I'm seeing as pleural effusion. Good. All right. What is Charlie? Ah, yeah, we see the fluid in the fissure right here. Right there. Can't normally see a fissure on an x-ray, but boy, it's right there, and I know where the fissures are normally at. Ballpark, so that kind of stands out there. What's Bravo? Parabronchial cuffing. Right there. Okay? Delta. Not gonna make you hold on. Right? And then alpha is gonna be that cephalization, right? So right there, look at the densities, very similar from upper 1/3 to lower 1/3 of the chest x-ray. It should be darker up top, but it's not. Here's a better picture of those curly B lines. Okay? And then here's a picture of the Cardi B lines. There was a class, oh gosh, maybe a little over a year ago, that kept calling them Cardi B lines. So I don't even know if she's like in the news anymore. I don't follow pop culture stuff. But if you see that, that's the bigger problem for the patient. Never mind their heart failure. Poor person has to listen to that all day. Sorry for this kind of detail. Parabronchial cuffing. Don't ask, because I don't know. No idea. When I first put this in there, I didn't even notice it, and I still like it for parabronchial cuffing, so someone pointed it out, I'm like, someone left their computer enter key in the chest, I have no idea. But parabronchial cuffing, fluid in the fissure, yeah. Blunting of the contraphrenic angles, otherwise known as pleural effusion. Minimum 300 milliliters because it's on the PA. All that stuff you can obtain from just this x-ray, right? All that really good knowledge, really good testable quizzing knowledge. All right, questions. Remember, congestive heart failure is a final common pathway, right? So we will get into some of the other things after the break. Take 10, come back at 2 after.
all your legs and stuff. You know,
I was like, nobody wants
I mean, they're racing in Oh, yeah.
I've never been, but I always wanted to.
Oh, watch the races.
Oh,
No.
nice.
No. That's not race weekend starts on, well, it starts Thursdays, the practices, Saturdays, it's qualifying. No, it's practice. My dad has YouTube.
ESPN Plus.
Is it free on?
Yeah.
So you have the basic.
So he said
Yep.
He was like, me and you got this. You know, and then same with the iron deficiency. I was like, I'm not those.
Not as sure. Oh, yeah. So that is yeah, I just this sounds good.
What was the last class? I'm definitely, yeah, tomorrow I'm definitely.
see? Yeah. It's still 30 minutes, but he's just helping us to move it.
I have no data.
Go ahead.
I can't log on.
Y'all being serious. This is your fault.
It could be one. There's no rule. So we got someone too.
Yeah, but
Why are you Trash. No. He doesn't game. Well, dude, back in 6 is total. Dude, as soon as fucking. It's post play. It's post play.
Yeah, is it on,
No, it's not.
It's not fun to do like.
Yeah, I know, I was feeling like.
Dude, I can help.
You were just like, I know, like, I'm gonna talk to her.
You know?
Well, like,
Dude, it's.
I also had to be different days, so I haven't been eating well, so
You stop. You decided not to be clean.
yeah, it could be.
Correct. So, I got a really again, I got the Call of Duty, so I was just spotting around.
Yeah, no. Call of Duty sucks. Yeah. Doesn't buy.
You don't even know about Fox on CXR. That was like back when I started playing on
Make sure all settings are good to go. I'm having Natalie on the phone in case
It's so satisfying. Yeah.
Yeah, well, that's bad.
Just like a 5-second ripper, and I was like, "Hey, you feel any better?" And I woke him up with this crying. He was in our bed all night.
See on that farm, the weight volume math.
Emotional. Support. Full service. Get to tell me what it's like. Is it about programs like
Oh my god. My feed's getting spammed by all this like medical stuff.
That was bigger. I'll just take somewhere.
I'm gonna put her down.
Yeah, of course.
She's still not getting x-rays. Anybody who wants to like have a extra one.
Alright, let's take our seats, let's jump back in. Jump back in.
I might take it.
Alright. Now let's talk about X-ray findings for hypertensive cardiovascular disease. Yes, hypertension patients can have abnormal X-rays. Now, a lot of the times, if you catch it early, they won't, right? Bless you. A lot of times you catch it early, they won't, but you can have some abnormal findings on that. One of the things you'll learn in cardiology, I believe it's still in there, is that any newly diagnosed hypertension patient, anybody who's newly diagnosed with hypertension, at a minimum, if you're diagnosing them, they never had it before, you should get a chest x-ray and EKG. Why? Do we expect to see anything if you've newly diagnosed them? Baseline. I need baseline. I need to know what the chest x-ray looks like today, and I need to know what the EKG looks like today, so that way, in 6 months, 2 years, 4 years, when they start having symptoms, and I'm going to evaluate these things again because they're not feeling good and they're having issues, I have something to compare my x-ray and my EKG to know if it's different or if this is their normal, right? But hypertension. Essential primary hypertension is the most common. 80-90% of people who have hypertension end up with primary hypertension. It just means it's not caused by anything else. The other 5 to 10% of people have secondary hypertension, means it's being caused by something else. A lot of times something wrong with the kidneys will cause that. That'll be a secondary hypertension, right? Not a primary hypertension. There's another one of those fun like statistic things. Like 5 to 10% is secondary, but 18 to 40 account for 30% of hypertension. That means 18 to 40-year-olds account for overall 30% of the hypertension that we see, whether it's primary or secondary. But most of your under 40s are going to be in the secondary hypertension realm because they're not old yet. They haven't been smoking for long enough. They haven't been drinking for long enough. They haven't been, having hopefully bad diet, unhealthy lifestyle for long enough to actually cause the hypertension. Most hypertension, primary hypertension, starts after age 40. But what symptoms are we going to have? I don't know, my favorite, asymptomatic. That's a great symptom. I mean, yeah.
What point is it considered a primary hypertension? What
It's not a value, it's what's causing it. So you'll learn a hypertensive workup in cardiology, and what you'll do is when you have a patient that you think has hypertension, you'll then do a laboratory workup to try to see if there's something else that could be causing the hypertension. Like I said, a lot of times it's kidney function or something along those lines. And so it's not a value of primary versus secondary. It's is there anything else besides the heart that is causing the hypertension? And you do that by further lab evaluation.
I would do that as far as
So you mean hypertension in general or primary versus secondary?
oh, just hypertension.
Hypertension in general. Gotcha. Again, more for cardiology, but technically, depending on the guidelines you go by, 120 over 80 is normal. 120 over 80 is normal. So if you're above that, depending on what guidelines you're looking at, some say 130 and anything above 80, so it's something 130 and above should be hypertension. Anything over 80 should be hypertension. Some still say 140, right? It just all depends on what guidelines you go off of and kind of what you're looking at. What I would say in clinic, if you're doing the evaluation of hypertension, if they're in the 120s and like 82, I'm probably like, yeah, you're fine. Especially if they're coming in, they're sick and they're in pain, probably not concerned about it. Anybody in the 130s and anybody who's creeping up on 85 for me, I'm starting to evaluate for hypertension. Right? But you'll get those really specific numbers based off of either the JNCA guidelines or the USPSTF guidelines from Commander DeBoer next semester. But you'll see that we're going to teach you academically, but it's kind of a grayish area of hypertension. For sure, 140 over 90 right? For sure, that's a line. And the reason I say that is you will learn that when you're treating hypertension, your goal is not 120/80 or less. That would be nice, but that's not the goal. What's considered controlled treated hypertension is if you have a hypertensive patient on medication whose blood pressure is less than 140 systolic and less than 90 diastolic. That's considered controlled. It's technically above normal, but they're still a hypertension patient, but that's how you know you're treating them appropriately. So that's kind of but recently I think the American College of Cardiology has dropped that down to 130 and I think down to 85, just because we have so much hypertension in this country and they're trying to get people more controlled. So, but symptoms, right? Asymptomatic. There's a reason they call hypertension the silent killer. Right? They still call it that. They did for years because patients don't come in to the doctor. They feel fine until they don't feel fine. We find out for years they've been running high. Or my favorite is you find somebody with hypertension and you want to work them up and you want to treat them. They're like, no, I'm good. I don't need no meds. I feel great. I feel fine. Why do I need a medicine? I can still do all my stuff. I feel good. Meanwhile, they're sitting like 146 over like 95. We really should get this under control. Nah, I don't want no meds. I feel fine. So you tell them silent killer, you'll learn all that in cardiology. But asymptomatic is very, very common. You can have chest pain, shortness of breath, dyspnea on exertion, and orthopnea. Why? Because it's a cardiopulmonary disorder, and that's what happens when those things start not working well, you start getting those symptoms. But it's very nonspecific, right? But on imaging, what are we going to see? Maybe uncoiling of the aorta, both ascending and descending, and left ventricular hypertrophy. Why left ventricular hypertrophy? That's what's pushing, right? The heart's a muscle. The heart has to squeeze to push the oxygenated blood to the body. The harder the heart works, it's like going to the gym, right? You go to the gym, you start doing workouts, the harder you work, the brain goes, oh, you're working harder, doing all these lifts, so I'm gonna create more muscle tissue to help you out, to help you get stronger, because you're using this more. That is a wonderful effect that our brain has on our body. And it's good news for every muscle except for the heart. The brain is only as smart until it's stupid, right? This is the part where the heart is working hard. The blood pressure is squeezing, constantly at a high blood pressure, right? Working super hard. And then what happens is the brain's like, that's a muscle. It's working harder. I'm going to build more cardiac muscle to help it out. That's bad. That actually makes the heart weaker. So as that muscle is growing, that's causing left ventricular hypertrophy. It starts to grow, and we see it on a chest x-ray. Here's the crummy part about it and why it's so bad. And this is the explanation I use for my hypertension patients to get them on medicine, as I try to explain it. The damage that is caused to the left ventricle as it gets bigger, we cannot reverse. What's done is done, right? They get left ventricular hypertrophy, that muscle is enlarged. But the catch with this is the muscle grows inside and out, but more to the inside. So what happens is it gets thicker, but it grows to the inside of the ventricle, which then makes that left ventricle smaller, which now means it can fill with less blood per heartbeat. Well, guess what? The body still needs the same amount of oxygenated blood. So in the feedback loop, the body's telling the brain, hey, I need more oxygenated blood, you're not giving me enough. So what does it do? It works harder, it works faster, it grows bigger, ventricle gets smaller, so on and so forth. And that's the danger of that uncontrolled hypertension. And when we get to that left ventricular hypertrophy. So if you understand that anatomy of what's squeezing, then you understand why that's what causes that to be enlarged. Okay? And shocker, last bullet on there, it can lead to CHF, like we've already talked about, and all the imaging signs associated with it. So, here's an idea of what it looks like via x-ray. I show the CT. You're almost never going to get a CT for hypertension. This just happened to be a CT of somebody that were looking for something else, and they had hypertension, and I really like it because it shows that thickness of that left ventricle compared to the bottom part of the right ventricle there. Look at how thick the wall of the left ventricle is on that CT. That's what's happening here. That is your cardiomegaly, your left ventricular hypertrophy, primarily focusing on really the space right here. We have not had a very small space like that on our chest x-rays for our normals. It's usually a bit larger than that, the lung tissue space. But that is an enlarged left ventricle. What we also end up having is uncoiling of our aorta. So this whole thing here, can't really quite see the arch, is basically the aorta. So because of the constant pressure into the ascending and descending aorta from the left ventricle, the aorta starts to cave under the pressure, it starts uncoiling, it starts widening, right? And so that's, if you remember on our normal, we would have our normal right atrium here. But I have this larger line coming all the way up into the aorta root area. That is the ascending aorta starting to uncoil. Then you follow it around and you start to get the descending aorta following these arrows all the way down, coming down on the other side of the chest x-ray. Yes, sir?
So that top arrow that you have in this image, sir, is representing aorta where it should be the aorta notch.
So yeah, so we should just have just this,
Okay.
right? But look, I got it coming down all through here. That's what that's kind of showing you there.
Second arrow, left ventricle, we can see the widening of the aorta.
So correct, this arrow too is also widening the aorta. This arrow is showing you the left ventricular hypertrophy. Okay, so it pivots outward and uncoils. Does everybody see the uncoiling compared to the normal that we've seen? Right? And I want to be clear, it can be only the descending aorta if it hasn't gotten that bad yet to the ascending aorta. It doesn't have to be both, but it can be both. On this one, it shows both, but you can also have just the descending aorta causing some widening or some uncoiling in that as well. Going to another one here. So, got my normal. Okay, and what I will show you here, this one's kind of hard to see, so I recognize that, but I have my aortic knob, and instead of my bumps, like I normally have, it comes out, and it's just coming right down. Right, I don't have the knob that I was showing yesterday, right? I don't have that nice little circle. Kind of comes out and just rotates right down, showing the widening of that descending aorta. Versus here, where I'm like, oh, there's that. I got my little divot right there, and then my divot here, so I can kind of make out, right? But here, I don't have that. It just comes down and just continues to rotate down. Cardiomegaly, there as well. Okay. So everybody kind of see what we're looking at with the cardiomegaly versus the uncoiling of the aorta, okay? What are some of the differences here between this and congestive heart failure? This is commonly an asymptomatic patient. Congestive heart failures are usually not asymptomatic, okay? That's gonna be one of those things, all right? And then when we look at the chest x-ray, so we got some of that uncoiling, but then I would turn around and go, okay, what am I looking for here? Do I know my congestive heart failure stuff? All right, looking here and here, yep, that does not look like cephalization. I am darker towards the top than I am towards the bottom. I'm looking for fluid in the fissures, I don't see that. I'm looking for blunting of the costophrenic angles, I don't see that. Parabronchial cuffing, I got big blue arrows hiding some of the material, I recognize that, but from what I'm looking at, I don't see that, right? And they're asymptomatic or not having that nocturnal dyspnea, those kinds of things. You use all that to go, hey, could this patient end up with CHF? Yeah, they absolutely could. But right now, I'm just treating hypertensive cardiovascular disease. I'm not treating CHF at this point in time. We haven't progressed to that yet by both symptoms and or radiological imaging. Okay? Pulmonary arterial hypertension. Another type of hypertension, but this is specifically hypertension within the pulmonary artery. How do we get it? We don't really know. Idiopathic. Oh. Familial, yeah, there's a family trait there for sure, for the primary. It could be secondary to emphysema and mitral valve stenosis, it likely is, but again, we don't really know what is causing those things to lead to the hypertension. So again, think about that. Think about the anatomy. with the mitral valve. This actually kind of makes sense. With where the mitral valve is and where the pulmonary artery is, if I have stenosis of the mitral valve, that means it's stiffened, right? It's stuck. It's hard to push stuff through it. So the body's going to continue to try. That's what's going to lead to pulmonary arterial hypertension. Since what I did at the beginning, I was like, if you know your anatomy, you can kind of work yourself kind of through this. What's the abnormality? So if I work backwards from the abnormality, where's the issue going to be, right? And so that's where the pulmonary arterial hypertension goes with that mitral valve stenosis. Your symptoms, most of your patients, dyspnea, fatigue, maybe some syncope, chest pain, palpitations, wonderful, all these same symptoms, right? Chest x-ray is your initial study. Your hallmark finding is going to be the pruning. It's going to be kind of hard to see right now. I'm going to try to draw it out for you to help you kind of visualize it. I'm going to tell you right now why they call it pruning, right? So far, before I go to the image, so far, when we've looked at chest x-rays, normal chest x-rays, we've talked about the pulmonary markings, the lung markings, right? The vasculature. And it kind of branches out from the lungs, branches out like a tree. All these kind of branches coming off the central area to fill the lungs with blood and fluid. Think pruning a tree. When you prune a tree, what do? You cut off the small branches and leave just kind of the big areas, right? So what we're going to see in the centralized markings, we're going to see branching, but then all of a sudden we're going to see nothing. It's going to cut off. We're not going to see branches come out from the central area. And you'll see what I'm talking about when I get to the picture. But put that in your mind first. Pruning a tree, right? Cutting off the small branches. Ultimately, a CT with contrast is your study of choice on this, because what you're going to be looking for is your main pulmonary artery, if you remember, we looked at that already on an image, we're going to show it here too. Is your main pulmonary artery wider than your diameter of the ascending aorta? It's supposed to be of similar diameter or slightly smaller than the aorta. But if it is wider, that is enough for pulmonary arterial hypertension, because it's been happening long enough to widen that aorta. Okay. Can you do the pulmonary arterial pressure and all that stuff? Yes, you can, but I really use this one to kind of break down why are we having the issue. Okay, so it shows the heart there. Image of the hallmark is that pulmonary arterial hypertension is the pruning. Already said that. It's hard to figure out why, but the leading cause of death of primary pulmonary hypertension is right-sided heart failure. Why is that? Is there something going on in the lungs causing this to happen? We don't know what's causing it, right? That's why we say pulmonary arterial hypertension, we don't know what's causing it. We know it has mitral valve stenosis, a possible sign or symptom. We also know that where's the blood pushing in the pulmonary artery? Where's it going? Where does it go? It's a little bit different than the rest of the body. To the lungs, right? So could there be a pulmonary disorder or a pulmonary abnormality that is causing backup of that blood, causing issues and causing the hypertension that way as well? Yes, there absolutely could be. Could it be a mass that's constricting some vessels in there? Sure. Could it be like COPD or something along those lines that's stopping, causing obstructive issues with the vessels, causing backup, causing hypertension? Sure, it could be. Which is why when you have pulmonary arterial hypertension and we try to figure out what's going on, we want to look to the lungs as well. That's why it's in that name, the pulmonary artery, right? Look to the lungs. And that's why I say the leading cause of death is that progressive right-sided heart failure, which you will learn in cardiology and pulmonology, is if you have right-sided heart failure, look to the lungs to figure out why first, because that abnormality may be coming from the lungs. And a lot of heart failure will go lung issue, right-sided heart failure, then left-sided heart failure, just through the progression of the body. So, but let's see what we can take a look at in this aspect. So I want you to focus on my normal first, okay? I want you to look at your primary central vasculature, okay? Primary central vasculature, more so on the right side for this image than the left side, right? But look at that, and when I look at this and I see my main trunks, right, I got my small little vasculature branches kind of coming out here. I can see those fairly well. Got my main vessels, and I got the branches coming off like a tree that's nice and healthy. Then when I go to my pruning, I have my main vessel, but where are my branches? Where are my nice little branches? I can't see them. That's what that pruning is. That's that x-ray hallmark of being concerned for pulmonary arterial hypertension. Right? I can see the main vasculature, but I don't have my tree branches coming off, or at least I can't see my tree branches coming off in this area. That's pruning. Okay? The red arrow is also, it's supposed to be on x-ray, which I don't want you to pull it out this way. It's supposed to be showing you the enlarged pulmonary artery. There we go again. The enlarged pulmonary artery is supposed to be showing that there. It's meant there to be showing you that it's hard to see on x-ray. The enlarged pulmonary artery is very difficult to see on x-ray and pull out. Darn near impossible for a non-radiologist to look at that, which is why we use the pruning, particularly on the right side. Why particularly on the right side? Well, because I don't have the rest of the cardiac silhouette in the way of those vessels, right? I can see that a lot better on the right side than I can on the left. There's nothing obscuring it. So we use that pruning as the hallmark sign because it'd be very difficult to pull out the pulmonary artery on an x-ray, okay? This is the CT I was talking about. Remember, your pulmonary artery is that thing that's kind of shaped like this. This is your ascending aorta. This is your descending aorta. If the width of the pulmonary artery is more than the ascending aorta, that is pulmonary arterial hypertension. I don't need anything else. I see it right there. We're good. That's enough to diagnose it. The pruning, you might be like, yeah, maybe, maybe not, right? But if you get really good at it, like I see the pruning, they've got the symptoms, we're going to diagnose it. I'm good with that. But definitely with the CT, with contrast, you can see that. Now you need the contrast, right? Because I need to actually be able to see where one vessel starts and the other one stops and the other one begins. And I can't do that without the contrast because blood and soft tissue are going to look the same without that contrast on a CT. Make sense? Yeah? Okay. Let's jump into specifically mitral stenosis. Okay? This can cause either right or left-sided ventricular failure. Look at the symptoms: dyspnea, desertion, anosmia, paroxysmal nocturnal dyspnea. That's not CHF, but it's mitral stenosis. Okay, well, what the heck? And then I go into the imaging and go chest X-ray is initial. Okay, great. I got curly V lines. Well, that's not helpful. That was part of CHF. But what is in this that is different than my CHF and anything else we talked about before? So the echo for the study of choice, yes. So good for diagnosis on that, right? Because I'm looking for valves. So I need an echocardiogram to look at the valves. I need to see the functionality of those. But it's that first bullet. Maybe the second one, but more the first one. Left atrial enlargement. Again, think mitral stenosis. Or, yeah, where is that mitral valve? It's in between the left atrium and the left ventricle. So if it can't open and it's constant pressure from the left atrium trying to push blood through, the left atrium is going to enlarge. As opposed to the left ventricle enlarging through hypertension, or what's going to be like aortic stenosis, right? But the left atrium is going to enlarge. It's the only one so far that we've seen left atrial enlargement. Some of the stuff, the symptoms on this left side are very similar to CHF, right? Very similar to CHF. But CHF doesn't necessarily have left atrial enlargement unless your CHF happens to be caused by mitral stenosis that just got to the end stage disease, right? So then you're going, what is CHF? It's a, why are we having it? If I have congestive heart failure on an x-ray, and I have the symptoms for congestive heart failure, and then I have my x-ray which has left atrial enlargement, mitral stenosis until I prove otherwise, I now have my reason for my CHF. See how that flow kind of works, where these things are now teaching you, based off of the other abnormalities you could see, what might be the cause of that final common pathway. Okay? Echo is going to be your study of choice. Used to be kind of big for rheumatic heart failure. It's kind of been decreasing in that. Part of the reason that rheumatic heart failure has been decreasing, but it's still prevalent, so something to keep in mind that mitral stenosis can happen from that. Gives you your common symptoms, again, either left heart failure, which is very similar with the CHF stuff. The biggest thing is it leads to obstruction of blood flow from the atrium, like we talked about. Left atrial pressure builds, it enlarged, causes pulmonary venous resistance, then eventually pulmonary venous hypertension continues to work its way back, all the way into that, right? You get cephalization, it'll eventually lead to CHF. We kind of covered all of that. The venous pressure goes up, the pulmonary arterial hypertension goes up, the right-sided heart failure. But, left atrium, left ventricle. Look at where my left atrium is. My left ventricle is all the way out here. But look at how enlarged my left atrium is. Okay? We got cephalization in the yellow circles. See the cephalization in the yellow circles. Okay? And we're starting to get some right heart enlargement due to the right atrium getting enlarged and ventricle getting enlarged as well. So this is one of the ones where it has progressed further on. This patient is really sick, right? I got my sternotomy wires. I got my aortic root, so maybe I got some regular hypertension going on here. This is a very involved chest x-ray. It's just meant to really focus on the yellow arrow and knowing the biggest thing that I want you to know is where is the left atrium on the anatomy? What does normal look like? Is the left atrium enlarged? If the left atrium is enlarged and you know where it's at, you think you mitral stenosis. That's the pathway I want you to take because the symptoms are going to be the same as a lot of this stuff. Now if we flip to aortic stenosis, right? Aortic stenosis is going to be, again, asymptomatic. Why would that be asymptomatic? Because we just can't feel that area. It's very similar to the hypertension stuff. When it gets severe, you'll get some dyspnea. That's the most common symptom. Usually it starts off with, hey, I was having difficulty breathing with doing activity, and now it's getting worse and I'm sitting at home. And I feel like I'm having a hard time kind of breathing. You can have syncope, exercise-induced angina, congestive heart failure. The biggest aspect of this is very similar to the flow of where that aortic valve is at compared to the mitral valve, right? So you're going to get left ventricular hypertrophy. This time it's not due to hypertension. It's due to the aortic valve not wanting to open, so it has to squeeze harder. It's not just hypertension, it's aortic stenosis. So the left ventricle is going to get enlarged. It's going to cause that diastolic dysfunction like we talked about already. When the left ventricle enlarges, I have less of a chamber. So when the heart relaxes and it doesn't go into full diastole, it can't fill up with enough blood. So I have decreased function there. And then it leads to systolic dysfunction, congestive heart failure, syncope, like all kinds of badness. The key thing with aortic stenosis is going to be under, right here. How are we separating mitral stenosis from aortic stenosis? Or, more importantly, because it causes left ventricular hypertrophy, and it causes diastolic dysfunction, and it causes all of those things that hypertensive cardiovascular disorder causes, what's the difference between aortic stenosis and hypertensive cardiovascular disease if I have a patient and I'm looking at an x-ray that has a large left ventricle? Do they have a murmur? Aortic stenosis will have a murmur. Most of your basic hypertension, regular run-of-the-mill hypertension, does not have a murmur. It's not a valve issue. This is a valve issue. Any patient with a new murmur that they've never had diagnosed, you listen, you hear a murmur, and one of those symptoms of dyspnea, syncope, or angina, it is aortic stenosis until you prove otherwise. Get an echocardiogram and find out. So again, for these things that we're covering that look the same on x-ray and present the same symptoms, what is the difference between aortic stenosis and hypertensive cardiovascular disease? The answer is there a murmur? Because they're going to look the same on x-ray. Yes, you're going to get a chest x-ray still as the initial study, right? Primarily used to evaluate the symptoms to make sure there's not anything else going on as well, right? Findings are kind of vague. Looks like hypertension. Doesn't necessarily help you. And that's why we get the echo. Okay. chest pain, symptoms related to heart failure, syncope, you're probably thinking aortic stenosis, right? Whenever you see things like triad, those are classic PANTS test questions, right? They love pulling things out of books and saying, oh, this is this triad or pentad or whatever. So, what are the causes? There's a lot of different things. It could be a congenital bicuspid valve. It could be degeneration of the tricuspid, rheumatic heart disease, right? The biggest thing is the ascending aorta is probably going to be prominent, but the ascending aorta with prominent hypertension as well, right? You might see calcification of the valve on a CT or an X-ray if it's really bad, but again, your study of choice. Anything valvular, aortic stenosis, mitral stenosis, I'm not going to talk about it in this course, but any tricuspid valve issues, anything valvular, your study of choice is an echocardiogram. You're not going to do it, you're not going to have to interpret it, which is why we don't cover it, but you need to order it because they need to look at those valves and make sure it's working properly, and if not, what needs to be done to fix it. Here is your ascending aorta that is not present here. Right? So that's what it's showing you is that the ascending aorta is uncoiling, kind of dilating out a little bit. We don't really have left ventricular hypertrophy yet. It's affecting the aorta first. Okay? But I don't want you to get hung up on what came first, the chicken or the egg, murmur versus no murmur when trying to figure out the hypertension versus the aortic stenosis for this course. Questions on that? Okay. There are two types of cardiomyopathy we're going to discuss. Okay? Dilated and hypertrophic. Guys, save this slide. Pay attention to this slide. Because I got news for you. Cardiomyopathies look exactly the same on imaging. Whether it's dilated or hypertrophic. Hypertrophic means enlarged, like thickened heart muscle. Dilated means enlarged, but not due to the heart muscle, which means it's going to look exactly the same on our images. But I have dilated cardiomyopathy is the most common form. Your patients with coronary artery disease, heart attack history, high blood pressure, diabetes, thyroid disease, hepatitis, HIV, alcoholism. American adults. You hear me say that a lot, right? But usually older. They've been dealing. This is not something like I have high blood pressure for 3 weeks. I just got diabetes yesterday. I started drinking, 2 years ago. This is stuff that has been going on for years, causing damage and causing issues. So usually going to be your older patients. Your hypertrophic cardiomyopathy, think young athlete, late teens in their 20s. How many of you all were high school athletes, right? What if your sports physicals? If your doctor was thorough enough, they should have done a cardiac listen, and they should have done something where they either told you to bear down or they squatted with you while they were listening to your heart. What they were checking for was a murmur or something that would show up only present when valsalvaing, when listening to the heart, to look for hypertrophic cardiomyopathy. These are the patients or the things you see in the news when you see like this totally healthy college athlete or high school athlete playing basketball, playing football, whatever the sport might be, and all of a sudden just dropped in the court in the middle of the field and dropped dead, like out of nowhere. And no previous abnormal medical history or anything, otherwise healthy, and no idea why. This was a hypertrophic cardiomyopathy that was missed during their sports physical or their physical exam. So this is typically your late teens, early 20s. There's really no major symptoms. That's what it says. Often the initial symptom is severe. It's syncope or death. There's nothing that prodromes this, right? There's a family history of it. That might kind of lead you towards it. But again, as we talked about, somebody's always got to be patient zero on family history, right? So when you're doing your sports physicals, please do a cardiac exam also while valsalvating separately. And Major Klein will talk about this in peds as well. This is a big piece of that because you're trying to find that hypertrophic cardiomyopathy. Restrictive cardiomyopathy is on there. We're not really going to talk about it very much in this course. It's genetic. That's all you really need to know. I'll say that for Dr. DeVore. But I need you guys to distinguish between dilated and hypertrophic purely based off of patient presentation. okay? So what's the pathophys? We just talked about it. All those things right there. Your chest x-ray is your initial. Your echo is your diagnostic for study of choice. Your MRI is your most accurate. Don't get tied up. Why do I have that on there? Echo is your study of choice. That is your definitive study to diagnose dilated cardiomyopathy. Where the MRI comes in is after you confirm that diagnosis, you're probably now going to order an MRI or an MRA to figure out how bad is it, to get that cardiac ejection fraction and the dimensions. That's going to be good for the cardiologist. But that is not something you're going for the initial, I'm trying to diagnose. Chest x-ray first, you see the enlarged silhouette, you got some of these symptoms, you're like, all right, let's get the echo. Again, valvular cardiomyopathy, let's look at the heart. We'll get the echo for the diagnostic study of choice. There's what your x-ray looks like. Cardiomegaly, right? This is your dilated cardiomyopathy, but your hypertrophic cardiomyopathy is going to look pretty much exactly the same. So you're just seeing a large cardiac silhouette, you don't know why, you start doing your investigation. Your hypertrophic, look guys, it's the same. X-ray initial study, echocardiogram study of choice. The difference here is the kids, okay? They might have dyspnea on exertion and angina. Those are the most common presenting symptoms in patients that actually have symptoms. But a large majority of them never develop the symptoms, okay? One of the ways you can tell is sometimes parents might not know, and I have it in green down there, if they have any family history of sudden death, especially in younger people that were athletes, this kind of increases it on your radar. They may not know that it was HOCM. HOCM is the abbreviation for hypertrophic cardiomyopathy. They may not have known that it was HOCM, but if you ask that question and they're like, yeah, actually, we had a cousin or like a second uncle or whatever, like died when they were like 21, just kind of out of nowhere. Have that kind of in your mindset of making sure you evaluate for this, okay? Chest x-ray, the heart size could be enlarged, maybe normal in a lot of things, but really I'm just kind of showing you here what the same concept is. We have the hypertrophic, it's got that left ventricular hypertrophy, infants, teens, and young adults, right? Infants, teens, and young adults, okay? You can have LVH in end-stage disease. Treatments down there, beta blockers, you'll learn that in cardiology. Okay. But again, I have cardiomegaly. Okay? Yes, this patient's on a pacemaker. But dilated versus hypertrophic, purely patient-related. So understand those patient symptoms for this course. There is more, but we are a radiology course. So when I have something that the images look the same, that's how we're going to distinguish between the two. All right. A couple more things. Aortic aneurysm / dissection. We're going to kind of talk about both in the same area, okay? So what is an aneurysm? It's a widening of the aorta. Have you guys in Clin Skills 2 started measuring the aorta yet, the abdominal aorta? Kind of? Oh yeah, it feels fine. I can't really feel it. Yeah, because y'all are normal, aortic-wise, right? So you're not going to feel a whole lot of it, but what you're looking for is that abdominal pain or that pulsatile mass. When you do feel it and it's larger than what it needs to be, you'd be concerned about that. The trick with this is 75% of patients, again, are asymptomatic with this aortic aneurysm. Fantastic. How do I find it? Well, that's why we're teaching you to measure the size. You might be able to find it that way, okay? But for the patients that are having pain, you're going to have that abdominal pain, that pulsatile mass, or the next below down, that ripping, tearing back pain. If they have the ripping, tearing back pain, we are then going from aneurysm to dissection, okay? Aneurysm usually comes first and then leads to dissection. So what happens is we have the aneurysm, the aorta is wider, it's weakening from the increased pressure, so it's getting wider. And then if you remember from A and P, how the vasculature walls of our aortas have multiple layers in it, right? They have like 3 layers sitting in there. So what happens is from the pressure, there gets to be some damage in that innermost layer, and then some of the blood gets in between the innermost layer and the middle layer. It starts to cause pressure, and it starts ripping the layers apart. And so it starts dissecting the wall of that aorta. And so a patient comes in with like, I got this like tearing, ripping, back pain. That's that aorta, probably that layer ripping away. So you need to be more concerned about dissection as opposed to aneurysm. Aneurysm can lead to dissection, okay? Most of your aneurysms are asymptomatic. I have, not that it can't be possible, but I have not heard of a dissection that has ever been asymptomatic. It is very painful because of the peeling of that inner layer. So, chest x-ray, right? Or abdominal x-ray, because the aorta can be thoracic or abdominal, right? Study of choice. Are we gonna see anything or be able to diagnose the difference between an aneurysm and a dissection on an x-ray? No, right? We can see the widening of the aorta for sure, but we don't know if it's a dissection or not unless we get in with your CT, your study of choice. And on top of that, you've seen the x-ray, how the aorta kind of starts and it gets kind of wide, and you're like, oh yeah, I know it's an aneurysm for sure, but you don't know how involved it is. You don't know how much of the aorta is being involved because you just have this shadow. So if I jump to the CT as my study of choice, I can look at the entire aorta like we've been looking at and try to get how significant the aneurysm actually is, get a true measurement of the width of the aneurysm, right? If it is a dissection, see how involved it is, and kind of look at that. And that's why our CT is our study of choice. Your screening down there, this is an abdominal aorta, this is an abdominal one. You do screening to check for an aneurysm in any males that are 65 to 75 with a history of tobacco use. More than 100 cigarettes lifetime. Not pack years, lifetime. So more than 5 packs in their life, they bought themselves a screening during this age. Women, Really what it comes down to is for whatever reason, this is more common in men than women. So the screening is like, sure, you can do it if you want, but we don't like mandatory, like tell you it is a standard of care. But for men, it's a standard of care. Do it on the women as well. It's an ultrasound, right? Don't worry about this, but like the screening is a quick ultrasound just to measure it. So just do it. Don't worry about it. Of course. I'm not going to test you on screening. I need you to know what to order and how to see it on imaging. So we just talked about this, right? Defined as enlarging the vessel greater than 50% of its original size. I don't care about the numbers on this slide. Okay? You need to know that 3 centimeters is normal. Okay? I'm not going to ask you what the risk of rupture is. I'm not going to be like, aorta is 3.7 centimeters. What's wrong with it? That's not for this course. Okay? So don't worry about that. You can see an x-ray, but it's not sensitive enough, right? You're not going to find out how bad it is or how involved it is without getting that CT with contrast. Okay? There's your aorta. We've already kind of seen this, right? It almost looks like the hypertensive uncoiling. Oh, look, I got that there. I got that there. My aorta is aneurysm, right? Looks like I might have some left ventricular hypertrophy here, but what the blue arrows are showing you is the full line of the aorta coming all the way down. Okay? Greater than 50% of its original size. You see this massive aortic aneurysm. Right? So like, what does that mean for this? Well, if I were to just give you an asymptomatic patient with this x-ray and say what's wrong with them, I couldn't give you hypertensive cardiovascular disease and aortic aneurysm as the same choice because technically either one of those could be accurate, right? So there's the trickiness, like when I do, that's why I say, especially for mine, I'll say it again. Read the question, read the answers, because there can be multiple things going on with this, but what am I asking you, right? And sometimes more than one answer is correct, but only one will be present in the choices, right? And more than one condition could be going on. Here's another one that's worse. 67-year-old man, ascending aorta is abnormally prominent. That's right here, that's what that is, the ascending aorta there. Descending like all the way out here, right? That is not good. So just showing you what that looks like. Here's another example with the aortic root, a little more subtle, but that's kind of bulged out way more than what normal is, right? So normal is usually just kind of right here. This is way out here. I don't have left ventricular hypertrophy. on this one. So this one, we don't have hypertensive cardiovascular disease because I don't have the LVH, which goes along with that, right? So using those tools sometimes to kind of piece between it. This is more specific dissection slides. Remember tearing, ripping, chest pain, or back pain, sorry, tearing, ripping, back pain, think dissection. Same things, x-rays the initial study, kind of crappy. CT is your study of choice. CT with contrast is your study of choice. I'm looking at the vessel. I need to have contrast. I can't see the vascular without contrast. Don't worry about the Stanford type A or Stanford type B, that's not for me. Right, but technically there are two types depending on where the dissection starts. Because look at this x-ray. Oh gee, it's the same x-ray you just looked at. It's not. But it looks very similar to that thoracic aortic aneurysm that we looked at. But this one is actually a dissection. It does show a pleural effusion down here, right? Because I got my nice sharp angle here, but I don't have it here. Okay? Which sometimes when you have the aortic aneurysm looking thing on an x-ray and a pleural effusion on the one side, you can go, hey, this is probably a dissection because I got stuff leaking into the pleural space, probably due to that. But in reality, you're getting that CT with contrast because this is what you're going to find. Here is my main vessel with the bright white contrast. Look at how compact and thick that contrast is. But now look at this area here. Bless you. See how that has contrast in there? It's not as bright as the main aorta, but it's right up in here. There's a tear in there, and this is starting to dissect. So now what you have here is you have the innermost layer of the vessel right here. That's what that dark gray line is. That's the innermost layer of the vessel that is starting to peel away from the wall of the aorta. And now contrast is getting in there, and it's just pushing down and going further and further down. That's what a dissection is. You can see it here on the coronal as well. Contrast versus contrast. It's best seen on the sagittal because we get that nice candy cane appearance of the aorta and really kind of see where that dissection takes place. If this were just an aneurysm and not a dissection, you would just have a widened aorta with full contrast in the whole thing and just one density. Right? So it would basically be like all of this white would be filling up this whole area at the same color, at the same level of density if it was just an aneurysm. But because we have the two difference there, that's going to be your dissection in that aspect. Everybody see that? Okay, questions on that? Difference between dissection and aneurysm. Mostly it's the symptom, the initial and study of choice are the same. Right? But it's that tearing, ripping back pain. This is just another x-ray to show you another aortic aneurysm. Right there. But mostly focus on that one. That's all I got. Questions? That's a really dense lecture for being only 58 slides. When you're reviewing it, please don't hesitate to ask me to help clarify those things, those little nuances that make a difference. Right? So that way you kind of get it straight in your head. Have a good day.